Well, welcome everybody to Coffee Cases and Controversies at exactly 10. So we'll get started here. This is the one of the efforts of International Academy and C3 to keep you all engaged and have an opportunity to meet your friends virtually worldwide. I see that we have participation probably almost all over the world. I see a ton of people from Europe and Asia on the webcast today, so I think it's going to be great. It's my great honor and privilege to have Dr. Bill Fearon, who's really requires no introduction, but he's professor of medicine and director of interventional cardiology at Stanford. He was the first author of the FAME trial and has a deep interest and knowledge in area of coronary physiology. And he's going to actually teach us a lot today regarding microvascular dysfunction, as well as some of the new indices of our coronary physiology. I'm also joined by several of our moderators here, Dr. John Blair and Dr. Sandeep Nathan, both from University of Chicago. Dr. Blair and Dr. Nathan both very involved in C3 Congress. Dr. Gautam Kumar, who has initial experience with Coroflow software, has also joined us from Emory and VA in Atlanta, and Dr. Göran Olivecrona from Lund, Sweden, who is a tremendous interventionalist and one of the very high volume PCI centers in Europe. So without further ado, I'm going to turn it over to Dr. Fearon, who's going to start with the first case. As we go through the case, we'll be discussing different parts of this case, and it's going to be a great educational next 45 minutes.
Great. Thank you, Raj. And thank you to the C3 organizers for the invitation. It's a pleasure to be here. I just have actually two fairly short cases, but hopefully they'll highlight some of the like you said, the new issues that we're dealing with and new indices, and we can use them as a jumping off point for discussion. These are my conflicts of interest. So the first case is a 59-year-old retired police officer who now works as an investigator for the district attorney. He used to run marathons and was quite active, but more recently, he hasn't been as active physically. He does have a history of hypertension and dyslipidemia, and he came in complaining of chest pain radiating to his left arm, which occurred mostly with emotional stress. It wasn't as obvious with physical exertion. He underwent a nuclear perfusion scan that revealed septal ischemia, and then he was referred to me for a coronary angiogram. And I'll just show the sort of the main image. This is his left coronary, obviously, and the LAD. You see there's a large branching diagonal that's almost kind of like a dual LAD. And I think the thing that you notice is there's no real obvious obstructive coronary disease. And so, I think in many cases, we might just stop and say, okay, it's a false positive nuclear scan, go on your way, and we'll look for other causes. But you can do a little bit more thorough investigation, and that's what we chose in this case. This is the older system, the Coroflow system from Corvento, which has joined forces with Abbott, is available, or was available just on a research component, and now is being launched commercially. And the display is similar to this, but more automated and easier to use. But in any case, what you see here, and we can go into how we do this in more detail later, but the fractional flow reserve was 0.85, so above the ischemic threshold, suggesting no significant epicardial disease. Coronary flow reserve was sort of in the low normal range, but the index of microcirculatory resistance, or the IMR, was quite elevated at 53, above normal's 25, or normal's 25. And so in this case, basically, we can document that there's no fixed obstructive coronary disease. There's a low normal coronary flow reserve, and then a very elevated IMR indicating significant microvascular dysfunction. And like I said, this is very kind of a straightforward case, but I thought we just start with this one and use it to kind of open up our discussion about some of these new indices. So I'll stop there, Raj. And
yeah. So Bill, I'm very confused now because, why would you do all these different indices in a case like this where we clearly don't see any stenosis? And I was hoping that you could explain away, some of the differences between these indices, especially I see that you've got an IMR and then you've also got an CFR and FFR. So can you talk our audience through all of these different indices and give some basic understanding of it? And then I'll have some more questions.
Yeah, so I think that's a great way to start this case discussion before we get into details, is just to kind of go over globally, all this alphabet soup, because it really has become an alphabet soup. So, we started off, of course, many years ago with fractional flow reserve, and that index, being specific for the epicardial vessel, tells us whether there's ischemia, being produced by disease in the epicardial vessel. And, because FFR, can sometimes be challenging if you don't have adenosine or you don't like to give it, people became interested in facilitating measurement of coronary physiology. And, when FFR was first validated, resting indices were looked at. PDPA, whole cycle PDPA was looked at, but it was found not to correlate as well with, for example, PET scan in the original study. And so it was sort of dropped from the slate. But then, as the data for FFR grew and people started using it more and they wanted to look for an easier way, they started looking at resting indices as a way of avoiding, adenosine and making it a little easier. And that's where, IFR came into play, the instantaneous wave-free ratio, looking just during diastole. And, that took off after the DEFINE, FLAIR, and IFR Sweetheart studies. And so then the other companies wanted to have their resting index, and that's where all the alphabet soup really started getting more and more complicated. And, we have RFR from Abbott and DPR and a number of different resting indices. It turns out that these are all essentially equivalent. They look at various portions of diastole, or in RFR's case, it could include systole, depending on where the greatest difference is. But when you compare them, they all correlate very well. And so that's all with the epicardial vessel. And then the question is, well, in a patient like this, where we don't see any obvious epicardial disease, I think we're all learning and gaining appreciation that the microvasculature can also contribute to symptoms, and we need ways to investigate that. And so the standard way had been looking at coronary flow reserve, and traditionally it was measured with a Doppler wire. In fact, coronary flow reserve was measured even before FFR. FFR was developed to kind of overcome some of the deficiencies of coronary flow reserve. And coronary flow reserve interrogates the entire circulation. So it does both the epicardial vessel and the microcirculation. And that is a little bit of a limitation. And people were using it originally to look at epicardial disease, but they realized that it also is affected by microvascular disease. And so if you have a normal epicardial vessel, we tend to use it to look at the microvasculature, but you have to remember that you could have mild diffuse epicardial disease, and that could cause your CFR to be abnormal. The other issue with CFR is that it includes resting flow. And as we all know, in the cath lab, resting flow can change. If you've just sedated the patient, you may be very calm and you have a slow resting flow, and then you start poking the wrist or whatever, causing some pain, and then the patient's resting flow can go up, or if their blood pressure or heart rate change. So that's one of the limitations of CFR. And so about 15 or 20 years ago, we became interested in trying to find an index that was specific for the microvasculature, and independent of the epicardial vessel and more reproducible. And that's where IMR, or the index of microcirculatory resistance, came from. And basically, it's just calculating or estimating resistance in the microvasculature. And we can, it turns out with the originally it was the Ratty and then St. Jude and now Abbott pressure wire and the appropriate software, this pressure sensor can also act as a thermistor. And we can go into, show you an example of how we do it. But anyway, you can measure temperature and calculate or estimate flow as well as measuring pressure. And so you have pressure and flow, and then we can calculate resistance in the small vessels or microvascular resistance. And so IMR allows us to look specifically at the microvasculature. And you can do this also with a Doppler wire by measuring flow with the Doppler and then pressure. There's the combo wire. And so that's another way of doing it, so-called HMR. So I think those are the major indices. I've done a lot of talking there, so maybe I'll pause and let someone else make some comments.
So John, Dr. Blair, at University of Chicago, how frequently are you using some of these new indices to say, determine a patient like this, because the clinical issue, the way I see it is that, okay, well, we have a patient with chest pain and doesn't have epicardial severe coronary artery disease. So does he need a psychological consultation and lifestyle modification versus, does the patient have a microcirculatory dysfunction for which, we should be treating the patient with, some of the cardiac meds, and I think that, a lot of clinicians that are listening today, this is one of the key issues for them that, what is it? Should we call it a non-cardiac discomfort or cardiac discomfort? So I know you do a lot of this, and I wanted to get a sense of, in your day-to-day practice, how frequently do you use it?
Yeah, that's a great question. I mean, the scope of the problem is pretty large. Up to 50% of patients who go to the cardiac cath lab for angina have non-obstructive or normal coronary arteries. But if you follow the prognosis of these patients with angina, they have a slightly worse prognosis than patients without angina. So what's going on with these patients? It's important to separate the patients who truly have non-cardiac chest pain with patients who have perhaps microvascular dysfunction, epicardial spasm, or even myocardial bridges, which have their own prognostic implications and could additionally potentially explain the cause of their chest pain. So how do you do that? Invasively, you can do that, but you can also do that non-invasively. But usually by the time the patient comes to the cardiac cath lab, they want an answer. And it would be, it'd be regrettable if you just say, okay, we're done. Let's get a PET scan. Let's get an MRI. When we have solutions to sort that out right then and there in the cardiac cath lab. Now, we're all used to measuring stenosis severity indices with FFR and now the resting indices. But these newer indices, quote unquote newer indices, are actually pretty, it's kind of a revival of some old indices and old basic concepts in cardiovascular medicine. But these newer indices that are designed to measure really both the epicardial stenosis and the microvasculature, can be used to study the microvasculature in the absence of obstructive coronary disease. So in other words, if these indices like CFR, IMR are abnormal and you have normal coronary arteries, then you can assume that those abnormalities are due to the microvasculature. So how often does this come up in our lab? Probably once or twice a week, and that's without even really advertising for these patients. That's just kind of routine patients that get referred to us for chest pain, and we do the evaluation, and it turns out they have non-obstructive coronary disease or normal coronaries. In some other places that have chest pain centers specifically to evaluate these patients, and they get referrals specifically for non-obstructive disease, I'm sure it's higher, but that's just kind of our baseline. We are starting to kind of develop programs where we're specifically addressing that. And a lot of people in the Chicago region send me patients that have already had an angiogram and want to know if they have microvascular dysfunction. They get referred in. But this comes up about once a week, just based on excluding those referral patients.
Yeah, that's very important to recognize that there is a device now going to be available that's going to make this a lot easier. Gautam, you have a lot experience with this new software for Coroventis that's going to be now marketed by Abbott. Tell us a little bit about that. What can this software do? Can it measure FFR, RFR, IMR all in one shot? And is this the same wire or is it a new wire?
Raj, yes. First of all, the Corvento software, as Bill alluded to, has been available for research use for valves. So some of us have had the privilege of having access to this. It does use the Abbott pressure wire, and you can basically connect it up and measure all of these measures, FFR, RFR, IMR, CFR, all of these you can measure from the same wire using this software. So that's a huge advantage of that system. We've had pretty good experience with it. It's actually, for those of us who don't have a ready analyzer handy, it enables us a method of actually calculating this. Now, if with your permission, Raj, I'd like to digress. And since we have an esteemed panel of physiologists here, I'd like to take the contrarian opinion here so that they can all try and kill me. So what are you guys going to do? You're going to do all this fancy IMR. You're going to diagnose that, oh, look, this guy has got vasospastic angina versus microvascular angina. And one, you're going to start with beta blocker instead of calcium blocker. The other one, you're going to start with calcium blocker instead of beta blocker. And why don't you just put, okay, if he's got no obstructive disease, there's no mortality benefit of a beta blocker, we're just going to put him on a calcium blocker anyway, which is the first line treatment. We're not going to do any invasive testing. And we're going to go with the presumed diagnosis, a clinical diagnosis of either vasospastic or microvascular angina and take it from there. What's wrong with that approach?
Yeah, so let me respond as a clinician. I think that I see hundreds of patients every week. And I think that a lot of my patients don't want you to just throw a medicine at them. So I don't think it's that easy to just say, okay, let me give you a amlodipine prescription or a long-acting nitro prescription, and you just go try it. I think they want an explanation of why. I want to give them a medicine, besides, physiological indices. I think that clinically, I think it helps me explain the patient, first of all, what their problem may be and why I would give them medicine. But I'll let Bill respond to it. Bill does a lot of it, what he thinks.
Yeah, well, thanks, Gautam, for setting that up. I know you don't really believe that, but I think we and others have done series, and in our series that Jennifer Tremmel led, there were a good 10% or so of patients that looked like they had non-obstructive disease, but actually their FFR was quite abnormal, and they did have significant epicardial disease. Usually it's diffuse, and so maybe you're not gonna go ahead and stent, but in some cases you can have a focal lesion that's just you're not appreciating. It can also, like John had mentioned, myocardial bridges. You can, when you do IVUS in these cases, you can detect those if you don't see it already on the angiogram, and those might be treated differently as well. In some cases, even surgical unroofing. And then I think the most important, and in our series, it was about 25 or 30% of patients, you find that there's no abnormality. And that's, I think can be really helpful both for the patient, because you've said, look, we've done this really thorough evaluation. There's no significant circulatory abnormality, and that can really help reassure them. In addition, it helps prevent a lot of unnecessary future testing and unnecessary trials of different medications. So for those in the audience who don't really believe this can be helpful, I think hopefully that'll change your mind. Now, I grant that we need a lot more data on exactly which medicines to use for microvascular dysfunction, what order, what's most effective, or which to use in spasm. So we do have a lot of work to do, but I don't think we should just, say, just because, it's not going to have a dramatic change or whatever, we shouldn't bother.
So can I just,
Bill and Sandeep, both, I'll ask you something else. So if you remember, a while back we did a infused AMI study, and we were doing myocardial blast assessment in patients with acute coronary syndromes, AMI, who underwent PCI. And we found that those who had good myocardial blast score, which I believe is similar to IMR, which is invasively measured, there is long-term implications of these patients not doing so great. So I think that besides normal coronary angiography and measuring IMR, there may be some other areas where IMR can be utilized to say, how good of a job have you done? And lately I've been thinking a lot about thrombectomy again in acute MI. That when you do actually thrombectomy, I believe that you get better myocardial blast grade rather than doing a simple aspiration or a balloon. But I think this is something that needs to be checked out in future, that should we be doing IMR in these cases to determine their prognosis in future. I know Bill's done some work on this concept. Bill, do you do IMR in any PCI cases to assess prognostically that what you might want to do with those patients?
We have done that. In fact, one of our research fellows published a registry of a little over 500 patients where we looked at IMR after PCI in stable patients. And it turns out that an elevated IMR was a predictor of late or long-term risk of death or spontaneous MI. So, it was also a predictor of paraprocedural MI, but beyond that, it was. So I think that it's interesting, and I don't know that we understand fully how the microvascular dysfunction is leading to these endpoints, but it is clearly a marker of a higher risk patient.
Sandeep, I'm sorry I interrupted you and broke your thought, but go ahead.
No, that's fine. I mean, these are, I think, great case. I think because it represents every case that ends up on the table, without a clear stenosis. I was just going to sort of piggyback on the comment that Raj had made. Specific lesion sets, Bill. Can you talk about two things? Number one is the actual mechanics of doing this. There's a proximal thermistor and a distal thermistor, and of course a proximal pressure sensor. Positioning of the wire to really get clean results where you can get all of the different measurements. And then if you can talk a little bit about specific PCI cases, like maybe vein graft intervention, atherectomy, and infarct angioplasty, where there may be some additional value.
Sure, yeah. What I thought I would do is kind of show you the setup of how we do it. So as you mentioned, first we place the wire, kind of in the distal 2/3 of the vessel. And usually in patients with non-obstructive disease, we focus on the LAD because, we consider that the most important vessel. It supplies blood to half the myocardium in most cases. So the first thing, the setup, we have our manifold, and then we have a 3-way stopcock at the distal end of the manifold, and we can connect a 3C syringe. And the first thing that we do, and the wire, by the way, there's 2 Abbott pressure wires. One that is, you connect to like the Quantian system, and then there's one that connects via Bluetooth. It's so-called wireless wire, meaning you don't have a distal connecting, but it just has a little Bluetooth at its end, and that's the wire that you use with the Coroflow is the wireless one. But anyway, we flush our guide. You want to make sure that there's clear saline in the guide and no contrast, because the viscosity of the contrast can affect the flow, and also it's a mild vasodilator. So we do that first. You wait 15 seconds or so just to allow any effects of the contrast to wear off, and then basically you can do resting measurements first, and then you start IV adenosine. Some people have tried it with IC adenosine, and that can work, but I think it's easier with IV adenosine. And then once you have hyperemia, you do your hyperemic measurements, and basically you just do a 3 cc injection, and then you'll see on the monitor the deflection of the temperature, and then it automatically calculates the mean transit time down in the bottom of the screen, and it shows up on the display. And you do this 3 times. And if you're not happy with one of your measurements, if it's way like out, for example, if your guide pops out, you might get a funny measurement, you can go back and repeat it. And then it averages those, and basically the Corvento system will then automatically calculate your IMR, because simultaneously on the top here, we're measuring FFR. And you see the aortic pressure, like you said, measured from the guiding catheter, and the distal pressure measured from the wire. And so you automatically get your FFR. If you've done your resting measurements, you'll automatically get CFR and then IMR as well. And it's very quick. You saw how long that takes. I mean, the whole thing takes maybe 5 or 10 minutes, including, calibrating the wire, putting it down the vessel, starting the adenosine, and doing these assessments. Maybe I'll just stop there.
So Bill, I saw that you injected 3 cc's of. Is that just a normal temperature saline that's on the table, or is it a cold saline, or?
Yeah, that's a great question. So, contrary to like a thermodilution cardiac output, where it's very important that you have the exact amount of saline that you're injecting, and the temperature. In this case, you could use cold saline. We just use room temperature, and it doesn't have to be exactly 3 cc's. Basically, in order to calculate the mean transit time, it's sort of calculating the speed or the slope of the change in temperature back to normal. And that's a reflection. It's inversely proportional to flow. And so it's not really calculating the area under the curve per se. And so that's why it doesn't matter if you use cold saline, where you'd have a big deflection, or room temperature, or it doesn't matter exactly how much temperature you use, if that makes sense.
So Bill, the other question that I had is, there are people who have a microcatheter in there and use that with the saline injection. Is that something that you found to be of help, or not really?
Yeah, I don't think so. I haven't found it to be of help. I think this is more streamlined and easier with less setup. So I kind of prefer doing it this simple way.
Yeah, I agree with you as well.
Bill, during this measurement, is adenosine running, or this is off adenosine?
So if you are interested in doing coronary flow reserve, where you need the resting measurements, and in this case, I didn't show it, but we had done them. They're down here, the bottom, or the left-hand 3. You do those before giving adenosine, and then you start your adenosine, and you wait, a minute or 2. And once you have hyperemia, then you do these 3 measurements. So if you just want to measure IMR and you're not really interested in coronary flow reserve, you can just start your adenosine and do those 3 measurements.
I see. So IMR is during hyperemia. So
yeah,
you can do your FFR and IMR at the same time if you don't want to do CFR.
Yeah, and I think that's, in my feeling, one of the advantages of IMR, because it's during hyperemia. You eliminate the effect of changes in blood pressure or heart rate. In fact, we did a study where we paced people, we gave dobutamine, we gave nitroprusside, and we measured IMR before and after all of those interventions, and FFR, and it stayed very consistent, whereas CFR, of course, jumped around a lot because of the effect of those interventions on resting flow. Also with IMR, we're kind of measuring the minimum achievable microvascular resistance, which we think is a reflection of the health of the microcirculation.
Bill, I think a question just came through on acetylcholine and assessing vasospasm.
Yeah, well, I could go to our next case, because that, if that sounds good to you, Raj.
Yeah, that sounds great. Let's talk about that. Yeah.
One thing before we go to, I just want to go back to this, because I know John Blair probably noticed this, but
of course.
do you want to say?
Yeah. So I was going to say, I mean, you're the bridge expert here, Bill. But isn't there a myocardial bridge in the mid LAD after that first diag?
So I kind of glossed over that because we were going to just focus on, the physiologic measurements, but there was a bridge. We did do an IVUS in this case there, and it documented the bridge. It wasn't actually that significant a one, but if we have time, that's something we can also talk about, is the evaluation of bridge and treatment and so forth. So let's go on to this second case. This is a 50-year-old man who's a firefighter. Dyslipidemia is his only really cardiac risk factor. He presented with exertional chest discomfort. And so 1 year ago, he had a non-STEMI, and he was found to have a 90% mid-LAD lesion, which was stented. He had some improvement in symptoms, but when they persisted, he was brought back to the cath lab. This was 9 months ago, before his presentation to me, and a small diagonal that had been jailed by the stent was then stented, feeling that was likely the culprit. But he continued to have chest discomfort during exertion as well as during stressful situations. He underwent a stress echo, and they didn't really show any significant wall motion abnormalities, and he was actually able to exercise quite a fair amount. But because of his persistent symptoms, he was then referred for a second opinion, and that's when I met him. And so we performed a repeat invasive assessment. And this shows basically the LAD again. And you see there's some luminal irregularities. It's not a normal LAD. You also see, I don't know if you can see my cursor or not, but here near this second diagonal there's a stent in the LAD as well as in the proximal portion of that diagonal. But those look, okay angiographically. So then, we're left with, well, should we just tell them, everything's fine, or should we do more assessment? And so this is where the acetylcholine comes in. And so this is to look for endothelial dysfunction or spasm. And in this case, we usually there's different ways of doing it. We usually give boluses of acetylcholine intracoronary, and we start at a load like 20 mics and then go up to 50 and then 100, and then in some cases even go up to 200. And in this case, there wasn't anything real dramatic, but you might notice sort of in this mid portion of the LAD, it looks a little bit smaller than it had. And then when we go to the nitroglycerin, I think you'll see that it does look bigger. Again, it's kind of subtle. It's not real dramatic, I would say, but and it's not surprising that there might be some endothelial dysfunction given the diffuseness of his disease. So then we move on and we do a more physiologic measurements. And here you'll see we measured CFR, and the resting flow actually was quite slow. Normally we see around 1 second. Here he had a very slow resting flow. And the hyperemic flow wasn't as fast as we sometimes see, but the CFR ended up being very high because of this slow resting flow. And I guess, again, this kind of highlights, I think, one of the limitations of CFR. IMR was sort of in the high normal range. FFR was, I guess, would you say low normal or not quite in the ischemic range. So it was sort of a little bit of everything in this case. We also did IVUS to make sure we weren't missing anything else like a myocardial bridge. He didn't have any bridge, but you'll just see that he had this very mild diffuse plaque throughout his vessel going back. So, and there was a stent. The stent looked fine, by the way. So in this case, he had some mild endothelial dysfunction based on the acetylcholine, but not too dramatic. No evidence for bridging. He did have diffuse epicardial atherosclerosis. His FFR was just above the ischemic threshold. He had high normal microvascular resistance. And so here, I think things correlated actually pretty well with the stress echo. I mean, he didn't have any dramatic abnormality, but one could imagine that the combination of this could lead to some of his symptoms. And so we would want to continue with aggressive risk factor modification, assess lifestyle factors, make sure he's not smoking, exercise, dietary intervention, and then, make sure he's on a statin, ACE inhibitor, consider a beta blocker. Again, we can talk about some of the specifics if we have time. And Raj had mentioned earlier, in our program, we do have very close involvement with our psychologists who can be quite helpful in patients because this can be a debilitating syndrome, and they can help provide mechanisms to deal with the stress of that as well.
Yeah, Göran, in Sweden, this is interesting that, FFR is 0.82. I probably would have done something a little bit differently than what was done here. Why not to, dilate that whole segment, and extend, it's a focal stent. I would have probably put in a longer stent and remeasured the FFR. FFR 0.82 is pretty low. What do you think? Given that we're new to CFR, IMR, and my lab is pretty limited at the moment. With this indices. If I would have seen this, that's what I would do.
I mean, it's an interesting case, and thank you very much, Bill, for sharing this. This is excellent to see. We've got the Corvento system now fairly recently, and we are starting to do some IMR measurements and CFR and so on, but we're pretty much reliant on doing IFR and FFR, mainly IFR. But I think that in this patient, I would have started also by doing a pullback to see if this is sort of just diffusely diseased the whole way out. And that becomes, I think, one limitation of how we can treat patients if it's not, focality in the lesion areas. So, and those, I don't know how good the results are long-term doing surgery in those patients that, you say that the FFR would have been, 0.79, for example, with this diffuse type of disease. Is the prognosis fantastic if you put a LIMA to the LAD out there, or how is it if we do it with stenting the long portion of the LAD? I know Bill might be able to answer that.
We do, yeah. So we do, and did in this case, do a pullback in many of our cases when we're not sure. And in this case, it was diffuse disease, as shown also by the IVUS. And that's a great point. I think in some cases, LIMA to the LAD can be helpful. I worry when it's just in that gray zone, like 0.79 or whatever, about the patency of the LIMA. But we have had cases, like I mentioned before, where we don't really see any obvious epicardial disease, but we do an FFR and it's, like 0.65. It's not that common, but occasionally you can see that. And in those cases, I think, LIMA may be a more effective way than putting in a full metal jacket.
Bill, one of the questions that I had was, is there any kind of order in performing this test in a situation like this? Would you do an FFR pullback, then IMR, CFR? What's the order?
Yeah, so it's a great question. And I think I'd be interested to hear what other colleagues feel about this. And there is some controversy, depending on what center you're at, whether it's in the US or Europe, people do it differently. One concern when you're going to be, especially using acetylcholine, is that particularly if you're going radial and you've given a radial cocktail and you've given verapamil and nitroglycerin already, will that affect the reaction from the acetylcholine? And I think the purists feel that it does. In fact, the purists, like centers, will, if we have a patient coming in who's referred for this evaluation, we'll have them stop, their nitrates or calcium blockers, 24 to 48 hours before, just so that their system is completely clear. So, you could argue that if you're going to do this, you need to plan ahead. But I think some people will go ahead and do it, even if they have, gone radial. We tend to try to do the acetylcholine first before giving any nitroglycerin or adenosine. And then after that, we'll place the wire down, and then we'll simultaneously measure FFR, CFR, IMR, all at the same time, like I showed you. And then we'll finish up with an IVUS, because, you want to give nitro before you do your physiologic measurements and before you do IVUS, but you want to assess the endothelial function, ideally, before you give those things. So that's the way we do it. But again, like I said, there's other ways of doing it, and people have different approaches.
And Bill, with the acetylcholine, have you seen any spasm or issues with catheter entrapment and stuff if you're going radial?
I can't say that I have. There's concern about refractory spasm in the epicardial vessel of the coronary, and that can happen rarely. I mean, you want to have your nitroglycerin nearby, but typically it's very responsive once you give your nitroglycerin. That takes care of it.
Yeah, it's interesting when you look at the studies, like case series or large registry studies that have done a lot of the acetylcholine testing, is that it's remarkably safe. Very rarely would you have refractory spasm or spasm actually causing a myocardial infarction, rare wire complications, and heart block or arrhythmias sometimes can happen, but it's also very exceedingly rare. But it's remarkably safe across a number of studies across different countries. And this, Dr. Nathan and I are radial first operators, and just anecdotally, we just haven't seen that catheter entrapment in the radial artery. For some reason, it doesn't trigger that. But that's just kind of anecdotally.
There's a question from one of the audience, and I'll ask it. What's the process of obtaining acetylcholine in the United States? What process have you guys gone through at different institutions?
Yeah, that's a good question.
I know it's an ophthalmic solution, and we're kind of using it off-label, but what do you guys do?
Yeah, so it's Myocol is the name of the brand name, I guess, or whatever that we use. And like you say, it's eye drops, but it comes, you just have to mix it in saline, and we end up mixing it. It's like, I guess like 2 milligrams in like a liter of saline or whatever. And we end up getting like 20 mics per cc. And so then you just have basically a bag of it, and we pull up, whatever we need, usually just in a 10 cc syringe. And then you can start off with just a cc, which would be like 20 mics, and then 2.5 or so, which is like 50, and then so forth. And we start low and then just gradually go up. And we generally give it so what I'll do is I'll put, like, say it's going to be a 50 mics, I'll put the 2.5 cc's kind of into the guide, a little bit maybe gets into the coronary, and then I'll actually connect this like a 20 cc syringe with saline, and I'll pull back blood and the acetylcholine and sort of mix it, and then I'll slowly give that over about 30 seconds, because if you do give it in a bolus, you can sometimes see heart block. That can be a little disconcerting. And so we give it slowly over 30 seconds or so, and then we'll take a picture to see what it looks like. That's how we do it. Other places will give, actually an infusion through a microcatheter, and gradually titrate that up. That's another way of doing it as well.
Bill, I got a question for you that's a little bit on the fringe, but I think relevant for many of us in academic practices. We, like Stanford, like Emory, like so many institutions, have a lot of heart transplant patients, and over time, these transplant patients develop coronary allograft vasculopathy. Many years ago, we adopted routine IVUS for tracking these patients when you have relatively normal-looking coronaries, but then the allograft vasculopathy is building up in a very concentric fashion. Do you think indices of microvascular resistance have any prognostic value there for, sort of looking at what's going to happen to these folks and these grafts down the road?
Yeah, thanks for that question, Sandeep. So we've been very interested in that exact question. And for, almost like 20 years now, we've been doing, originally it was just CFR. And then when we were, developing IMR, started doing IMR and FFR. And initially we found that FFR correlated very well with IVUS. As you can imagine, even in normal looking vessels, there's this diffuse allograft vasculopathy. And so you'll get low FFR values. especially early on. Over time, you get progressive microvascular dysfunction. So actually your FFR ends up going up because you have microvascular dysfunction, and your IMR starts going up. And we have done long-term studies, and we found that IMR measured at 1 year was predictive of late mortality. We also have seen that the change in IMR from baseline to 1 year is a predictor too, because a lot of times the microvasculature is stunned at the time of the transplant, I think from the ischemic time and so forth. And so you have a high IMR if you measure it, a few weeks after transplant. And then when you come back a year later, if it's improved, that's a good sign. If it's still elevated, or if it's even gone up further, that's a bad sign. And it is predictive. And we're right now looking at which is more predictive, these physiologic indices or IVUS, or are they just complementary, which they may very well be. Yeah, so we've been very interested in that area, and I think we've learned a lot about the physiology of transplant patients.
Gautam, in your practice, one thing, we have only a few minutes left now. How frequently do you do FFR, or RFR or IMR after you have put the stent in? Because
yes,
that's even in our practice where we do a ton of physiology, we don't do it that often. Should we be doing more often?
So I am reminded of this panel that I sat on at C3 when we were still in Orlando about 3.5 years ago. And the discussion was on post-PCI physiology. And at that time, that was pre-defined PCI, and we really weren't aware. And I was like, well, I'm not a whole lot sure whether there's a whole lot of value to that. Now, obviously, that water has gone down the bridge. I don't characterize myself as an early adopter of all of these, but I think I'm considered early enough, nevertheless. I would say 3 years ago, it was 0% that I was doing post-PCI physiology. No, maybe not 0, maybe 5% post-PCI physiology. And at that time was FFR. Today, I am probably doing either IFR or RFR post-PCI, probably at least 50% of the time, sometimes even more actually, especially for bifurcation, side branches, especially for, when I think that, did I get actually a good result? We actually did one yesterday where, the RFR was 0.78 and, we thought we had laid enough stent and it was 0.83, and we had put another stent distally to make it get to 0.95. So yes, I think I'm doing it increasingly. I'm at 50% and probably still climbing.
John, do you have any thoughts? What?
Yeah, it's a really interesting question. I believe Nils Johnson published like a meta-analysis a while ago looking at post PCI FFR. And he demonstrated that the cutoff of 0.92 or something like that, if you're less than 0.92, you have worse prognosis post PCI than if it's higher than 0.92. Now that's pretty high. I mean, most people would be happy if they had a FFR 0.92, but I guess that's at the time of the PCI, immediately post PCI. The question is, what do you do about that? What happens if you have a post PCI FFR of 0.89 or 85? Certainly, if it's less than 0.80, most people in the audience and the panel would continue looking for a lesion to stent. But if it's higher than that threshold, but under the 0.92, the question is, what do we do about that? I'd be curious to see what the panelists think about that. In terms of, to answer the question, in terms of how often am I doing post PCI FFR? If I'm doing an FFR pre, usually what I'll do with the pressure wire X is I'll disconnect it, but leave it on, do the intervention over the FFR wire. It's a good enough wire. You have to take a little bit of care not to bend it, but it's a good enough wire that you can do most interventions on. And then following that, I just reconnect it and remeasure. So it's a very straightforward procedure to measure it. And I'm probably like Dr. Kumar. I'm probably about 50%, because the other 50% are going to be like really complex lesions, rotablation, bifurcation. And usually by the time I'm done with that, I'm not going to have enough energy to put the FFR wire back in, to be honest. So yeah, so I'm about 50% of adoption, but I'd be curious.
Yeah,
Raj, may I just make a comment?
please.
So I think, John, I tend to use the hybrid strategy here. And I think this is where your imaging and physiology needs to be integrated. And I think that's one of the greatest disadvantages that define PCI study. Only 10% of those patients, in those 500 patients, only 10% had any intravascular imaging of any sort. And I think that's really where the role of integrated imaging is important. If you're going to do this, that's where I would check my stent MSAs. Are my stents maximally expanded? Are they completely opposed? Do I need to go in with an NC, look at my stent size with reference to my vessel size? And maybe, in fact, you would have put in bigger stents if you had known that from the beginning. Probably, we can at some point talk about an Illumian 4 based optimization, whether that was done. I think, those are the types of issues that start coming up there.
Absolutely. I think that if we're going to be putting in stents and we want quality, we should be imaging every single stent that we put in, no matter what the complexity is. And doing, I think what you're alluding to is doing a post-FFR, post-PCI FFR is almost like putting the cart before the horse. You should really image it first and then verify with the post-imaging whether you have any residual resistance in the system. And if you do, then at least you could be rest assured that your stent is optimized, and you should think about whether this is just diffuse coronary disease or if you just or if you missed a lesion further up. But if usually if you're imaging, you're gonna see that lesion that you may have missed.
So, Gautam, if you remember, Bill probably does remember this. One of these study was presented at C3 a couple of years ago, and I forgot the name of the physician who presented it, but it was about post PCI FFR, and if you have a low FFR, what do you do next? Whether you post dilate the stent, whether you do additional stent, and also when you do post dilatation, you keep the balloon inflated longer. And then you remeasure. Now, practice like ours, where we do a lot of OCT, we feel that, okay, we made a decision of intervening based on physiology, but then we're going to guide the PCI based on imaging. And then I think that doing physiology on top of the imaging is complicated, because I'm not sure what I would do with it if I find a low number. Bill, you have any thoughts on, labs like ours that, does, a lot of imaging stuff?
Well, I think John put it well in that I think the imaging, in my opinion, it's really key for optimizing the stented portion. It can identify other disease in the vessel, but it still doesn't really tell you whether those lesions are functionally significant. And so I think, they're complementary, the information. I think if you want to optimize the stent, I'm not sure. I mean, sure, if you do a FFR or RFR or IFR across the stent, you can determine whether there's a big gradient, and that'll, identify a problem. But I think really, if you want to optimize the stent, imaging is the way to go. But if you want to make sure that you've treated the vessel entirely, I do think there's a role for physiology post PCI in order to assure that you have.
I think your case, Bill, that you presented is perfect here, because we're using these new indices here, the CFR and IMR. And in your case, the CFR and IMR were totally normal. So you can't, well almost, I mean, the IMR was borderline. So you can't say, oh, this is microvascular dysfunction, because you've basically, if I interpret this correctly, you've basically eliminated microvascular dysfunction as a cause of this patient's chest pain. And the FFR of 0.82, usually when you see that, it's either diffuse disease, a missed lesion, or microvascular dysfunction. So you have eliminated that number 3, and by imaging, you've eliminated the missed lesion. So then you're down to that one thing, and which is diffuse epicardial disease, which you know, it's controversial whether you should stent that or not. But I think that this case was perfect in figuring out exactly what's going on, and you could not have done that without getting the CFR and IMR in this case. Did I interpret that correctly, Bill?
Yeah, you're right on.
Bill, and you may have said this, just a real quick question. You did a pullback. Was there ever a sort of a finite step up, or was it just sort of, you know, I'm bothered by that vessel and 0.82?
Yeah, well, so it's a good question about, like, too, how do you define a finite step up? Like how much gradient should you see, and over how much distance, and, you know, at what speed are you pulling back? And so I think we still have a lot to learn. In this case, there was just gradual step up. There was no focal jump at any point. And I think, again, the IVUS sort of, you know, correlated with that, or right, you know, by showing that there was just this mild diffuse, you know, atherosclerosis throughout the vessel.
I'm going to ask the last 2 questions from audience before we conclude. Dr. Sarmiento Ander has a question. Which tool has more sensitivity, FFR, IFR, or CT FFR? Anyone?
Well, definitely not CT FFR. Just kidding.
Invasive.
Not CT FFR.
Do prefer the IFR, FFR over CT FFR. Okay. The second question is from Dr. Pradeep Radhakrishnan. How physiological is IMR as far as coronary flow is concerned?
How physiologic is IMR?
Yeah. He says for coronary arteries, there is a difference in the interventricular, interventricular and aortic pressure. Pressure when it reaches venular end is almost gone, and capillary flow is designed to be sluggish for nutrient exchange. So how physiological is IMR as far as coronary flow is concerned?
I think, I mean, IMR, it's you know, part of the measurement is coronary flow, but really what it is assessing is the resistance in the small vessels. And is there normal resistance in that bed, or has there been damage, whether it's structural or functional damage, to the vasodilatory capacity of the, you know, the arterioles and the capillaries, you know? So I think it's more assessing resistance than it is flow per se.
Great. Well, thank you very much, everyone. It's exactly 11. I'd like to be respectful of the time. I want to thank Dr. Fearon for taking trouble very, very early morning in California to be with us. A lot of learning. Thank you, Dr. Blair, Dr. Kumar, Dr. Nathan, and Dr. Olivecrona. Happy New Year to everyone, all our audience. This was the first webcast we had in the new year. I hope all of you have a great 2021, and I look forward to seeing you again in February.